And now we'll begin our next panel discussion. And for that, I'd like to introduce Dr. Yash Patel, who is the diabetologist at Swasthya Diabetes Care, Ahmedabad, and is the organizing secretary of SwasthyaCON 2021. So welcome, sir. And please introduce the other speakers, panelists.
Yes, indeed pleasure, Dr. Kavya. And yes, to make it in timeline, and we have esteemed faculties for our telemedicine certificate course, and to host this course along with for this interaction with our faculty, I would like to introduce our further the topics of telemedicine certificate course had been running throughout the last 4 days from 5th of January to 9th of January, and what we had were specially attracted delegates for the same. And to my faculties, I would like to make sure that the numbers get present to you. And the last number of yesterday night 9 p.m. when we closed, there were 2,613 individuals who had completed all 6 modules, and that was really your scientific feast made it possible. So what 6 modules we had were first led by Dr. Manoj Chawla. The theme of this module were unlock the doors of the new normal, and to the new normal how you build up, sir. That was fantastic. So the first was telemedicine guideline in summary and understanding. Then second talk which I did was diabetes clinics of tomorrow, how we are running to the new normal of unlocking the doors. Then Dr. Neglur, Dr. Vijay Neglur lead medical legal aspects of telemedicine. And to further, Dr. Shashank Joshi sir, who lead rational use of oral anti-diabetic drugs in remote consultations. To further note, we had Dr. Jyoti Dev, who represented the best uses of technologies in driving remote consultation. And at the end, we had Dr. Krishna Seshadri from Chennai, who did telemedicine cases and best practices for ourselves. And all 6 talks were fantastic. And to lead this certificate course to the further level, we have this panel discussion. And to make a note that all faculties and panelists are among with ourselves, and it is indeed pleasure to invite Dr. Jyoti Dev, Dr. Sheshadri, Dr. Manoj Chawla sir, and Dr. Vijay Neglur, Dr. Shashank Joshi on stage for or on in this virtual platform for addressing the panel discussion. Welcome all of you, sir.
Thank you.
Thank you. Thank you.
Thank you. So we can have the gallery view, so all speakers can be around, please. Technical team, yes, support us. So let's start the interactions. And to build on the interactions, I'll start with the Dr. Manoj Chawla sir. That we know you put up the telemedicine guideline. What a fantastic way! And to the registered medical person, this guideline was available. But do you see that is it mandatory for all registered medical practitioners to go through, or do we should make sure that it should be voluntary by nature, or should go for the compulsion to build on? Yes, Manoj Chawla sir.
Thanks, Yash. Thanks for having us here, and must congratulate you for taking this topic and doing actually this certificate course on the telemedicine guidelines. So what I do remember is once the telemedicine guidelines came and were published on 25th March post the lockdown, the guidelines did mandate that every registered medical practitioner in this country in a stipulated time, which I think is about a year and a half too, would ideally have to go through the guidelines and undertake the certificate course in due course in time and get themselves certified to be able to use the telemedicine. Now, of course, a lot of us here would believe that we were using some form of telemedicine or the other, especially in a chronic disease segment like diabetes. We've been using that in the past, whether it was an email consult or a video consult or a WhatsApp consult. Many of us here were already doing that, but we didn't have clear regulations or guidance or the legality of the same prior to this telemedicine guidelines coming in. So, which is good because it came in at the right time when people could, many more joined in this, and it was a need of the hour to reach out to patients through the means of telemedicine. And having that document, having the legal support, having the right means and understanding is extremely important. There still continues to be some confusion on certain aspects. And I remember having this conversation with Dr. Mohan as well once this was released, that any guidelines which come in are just an initial draft of the guidance, and things will evolve. And I'm pertaining to the use, for example, of insulin or injectable therapies in the field like diabetes through telemedicine. I think that's one aspect we can discuss further as this panel discussion proceeds. But the government authorities still say that it's mandatory for every registered doctor in this country to go through this certification and get themselves certified. Now, I would honestly not know that when you are certifying as a private conference or whatever, when SwasthyaCON gives a telemedicine certificate, is that good enough, or it is something else which is certified by the Ministry of Health and Family Welfare that one has to go through and get that validated certificate. But I think it's a must that everybody should go through that 48-page document, and or if not, I think we all have given a good summary of the whole thing, which makes it clear for people to understand.
So I believe in all of our efforts, and let's build on that. If something is coming up, then we'll build it to further level. And you all are around, so it's blessings to all the delegates and all participants. So now to build on the further interactions, we have Dr. Neglur among with ourselves. Sir, Dr. Neglu, sir, we have already seen the telemedicine guideline being cited for litigation after the sad demises of our famous Bollywood star. Do you feel that remote consultation is putting additional legal pressure on our busy clinical practices of clinicians, or now that they have to confirm the patient identity and other things also to build to communicate in the teleconsultation?
Yeah, I think first of all, thank you very much for making this effort of making this modular teaching on the telemedicine. It's a very good effort where even the MCI is also making effort to start a course on the telemedicine. So you are one step ahead of them. So congratulations for that. Yes, you said there are a lot of legal issues. If you look at legal consideration, it's one of the major obstacles for telemedicine. If you consider 10 obstacles that we have in the teleconsultation, whether it's a cost of therapy, infrastructure, there's no demand, expertise, and all that, so legal is again a major barrier for the teleconsultation because it involves, there's no proper training in the teleconsultation for most of the doctors. It is not included in the curriculum. So for the doctors are not exposed. So all of us, what we are doing is the WhatsApp kind of a treatment is not really truly a telemedicine course because it is much more beyond that, because it requires a standardized format, it requires a standardized tools. Of course, it requires a good consent form to have either to continue or discontinue telemedicine. There's a lot of ambiguity regarding the responsibilities and the negligence on the part of doctor. There's also concern about privacy of the patient's details, then the security of the patient information and the treatment that you give, how much the patient understood, and the no health insurance policy so far on the telemedicine has put certain restrictions on the use of telemedicine with a great kind of effort that we expect because of the legalities of the matter. So therefore, taking consent, as you said, is very important, and we don't have a proper kind of a format of taking consent. And of course, the risk management and liability is also very important issues. The guidelines, the protocol, and the best practice are not adopted still. And the fees, how much you should take as much as what you do during consultation, or you must charge more. It's also important. Secondly, when the patient crosses the boundary, say from Maharashtra comes to Gujarat in your state, so your state charges maybe much more than what in Bombay. So how much you're going to charge? All those cross-border questions are still concern, and therefore lack of the clear understanding on these matters. I believe that also it involves a lot of concerns regarding the telemedicine legal aspect is the product liability and safety, and the intellectual property to whom the data belongs is again a very important question. That is also very important to understand. And the infrastructure issues, the lack of connectivity, and patients understanding the intricacies of the telemedicine and getting used to these kinds of practice of giving sort of a consent and then giving detailed information that we need to arrive at a diagnosis is also important. That also is as per the ability of the patient to comprehend the details of the telemedicine. And of course, we have problems of consent, whether it's implied consent or explicit consent, where the patient himself approaches to you, then the consent is already implied. or when you approach the patient, then it becomes the explicit consent, which requires a detailed kind of understanding both by the patient and you. You did mention about the identity. It's very important that you need to have a good identity of the patient. You can't have an anonymous practice both on the patient side and on the doctor side. That's very important. You need to have a proper age. If the person is minor age, then you have to have somebody along with him who can give the proper history. So the age is also important. And you need to display registration number, any details. The appropriateness of drug therapy is important. We have a lot of issues during the lockdown with a lot of psychiatrists who are caught unaware by prescribing drugs which they should not have prescribed. The Schedule X becomes very important. So appropriateness of treatment is also important. The prescribing information should be also accurate. And the doctor can come under the liability of various kinds of telemedicine use. It can be a civil liability, it can be criminal liability, it can be vicarious liability, and of course the liability under Consumer Protection Act. So therefore doctor is exposed to so many kinds of liabilities, which becomes for difficult for a doctor to understand all at one stretch. Especially we are very poor in law, and knowing law is also very important. That not knowing law cannot make you excuse from these problems. So therefore I think it's important that we should also understand details of law before we enter into the practice. And I feel there are a lot of important aspects which are important, and in a short period of time, because the others also have to speak, I can't go through in the greater details, but this is a snapshot into what I have to say about the legal aspects of the telemedicine. Back to you, Yash. Once again, congratulating you.
We can't hear you.
Yes, you're muted.
Hello, yes, sir. We can't hear you.
Yes, you become no.
Hello, yes, sir.
Legal issues?
Hello. Sir, can we continue the discussion?
Yes. Sorry, I have to move to the
Just
another
a
place.
time,
And
yes.
So I got it. So there were plenty of questions that you addressed simultaneously, and that's what I was about to ask. Dr. Sheshadri is among with ourselves, and this was about Sheshadri sir, what Dr. Neglukar mentioned, that how we differentiate the imposter from the identity, and the identical person is there, or whether it is imposter on a patient side, then how would we take care? And all of you mentioned that, but to specifically how to distinguish the imposter from the identical person. Yes. Dr. Sheshadri, your voice is.
Are you sure that is Sheshadri there? Do you have his identity cross-checked?
Okay. The only way the password is curd rice.
Got it.
Yeah, it's a time to have curd rice now.
That is wonderful creation. Yeah.
Okay. So remember, we went through this in the module. I don't want to spend too much time on it, simply because most of our patients are actually nice people. But having said that, you are going to find this. The way I would like to approach all of this is not to look at it from a legal perspective, but from a risk management perspective. That you need to be applying the same standards everywhere. Meaning, even in your clinic, you don't just go ahead and say, even the patient sitting opposite you don't just start writing. It is a good idea to say that, you are so and so, isn't it? You're so many years old. This is your MR number. I'm verifying. A lot of times what I do now, and especially because our EMR is that way, I'm so sorry about the noise in the background. What I do is I actually tell them, look, I'm sorry. When a patient comes in and walks into me and says, 1 minute, I'm just going to close this door. Just give me.
So let's take on to the further level.
I'm sorry about that.
Yeah, sorry. Thank you, Sheshadri.
So
yes, please.
The important thing is that, that you go through this process, not with just in a telemedicine, but you actually do this process with everybody. I'm sorry, it takes me 2 minutes. That's what you say. And you say, look, I just want to look at this information. You are so-and-so. from this place? Is this your phone? Or can you tell me your phone number? I think it's a good, it is good risk management practice even in clinical care, in everyday clinical care, because you can have 20 Kavya Subramaniams, you can have a few Manoj Chavlas thrown in, if you're such a big practice.
But who's Kavya Subramaniam?
About that, even with mass, we don't know who is coming and who is going.
Right.
Yeah.
So I think it's very, very important to take a risk management approach and do this in our clinics as well. This is the new normal. I think when we talk about, it's not one rule for telemedicine, not another rule for another thing. I think that is a new normal. If you are in doubt, always, ask for proof. And actually, this is where, you need to train your front office to do these things, check the EMR, check the numbers, make sure. In our clinic, the phone number is the most important thing for the telemedicine, in the sense that we send a unique link in which only the person with that phone number can log in. So these are some technological things that you can do. So it means that, I don't go on one Zoom call and then keep people coming to the same link. They don't. They come through unique links. They don't come through WhatsApp calls. These are things that have been built in as technology advances. But I think this is a risk management thing that you want to go through with every patient, whether they're on site or on a telemedicine call. I will stop here. I think for a short question, I think it was a too long an answer.
Thank you. You gave me buffer. Yes, we have Dr. Jyoti Dev among with ourselves. Sir, your lecture was fantastic for the technology side. But what excites the most, or which technology excites you the most about the telemedicine?
That's a very good question. Because if you ask me what is the excitement for me, I started telemedicine and video consultations in late 1990s with Yahoo Video. And the major limitation used to be the broadband connectivity. And now with video consultations, like all of us are meeting without a mask, we can see each other very clearly. So I can see you very well. I can see Vijay sir, Dr. Krishna, Manoj. So all the smiles, all the visual cues are there. So the most exciting is the huge difference which has taken place, the huge transformation in the connectivity. But if you ask me, the biggest challenge in consultations now, when we are more or less, all of us are now having video consultations, because in between, even though we were practicing telemedicine, majority used to be the consultations over the phone and over the email. But now the major challenge will be, those are not there in the guidelines. In the guidelines, it is mentioned as the connectivity issues, but the connectivity issues for us will be wasting the time. So we'll be programmed for a consultation for 10 to 15 minutes, but at the end of a consultation, it will be 30 minutes to 45 minutes. So one dermatologist was telling me that for her, during the lockdown period, she was seeing 3 patients in 1 hour, but now when the OP is open, she is seeing 10 to 12 patients in 1 hour. And I foresee that this is going to probably get resolved very soon with 5G. And the majority of our patients getting used to using these platforms, including Zoom and other professional video platforms. Because another area where we are wasting time is the patient will be sitting in front of a light, and the light will be coming either from the back or from the side, and we cannot see the face. And then in between the consultation, they will disappear. They will vanish and they will reconnect again after 2 or 3 minutes, and the precious time is wasted. So we require the services of 1 or 2 other staff in the hospital for a dry run. And again, during the consultation, somebody has to be there with us along with the doctor. And that is again to save time. And eventually, because I am telling you, because recently, last week, there was a Telemedicine, that is the conference, the international conference yearly of Telemedicine Society of India, which I am also a part of. And there again, the fees has been discussed, because we are also discussing the fees, and the telemedicine guideline has stated that the fees should be appropriate for the consultation. So when you extrapolate the term appropriate, it could be based on the duration of the consultation, the type of the consultation, and the magnitude of the prescription. So I would say that what prescription has been delivered, whether a follow-up is required or not. So you can, of course, charge in aligning with the in-person consultation. But the problem here is when you are in a telemedicine consultation, even though it is an asynchronous consultation, responding to an email or an SMS, we have to again go back through the history. You have to go back to the electronic medical records, spend at least 10 minutes with the electronic medical records, review the history, and then only you can give a prescription, because now it is legal. It is a document when you are providing a prescription. So you have to be compensated for the extra time. And for the corporate hospitals, for institutions, they are losing on the investigations because patients are remotely contacting them. So the revenue is a major aspect. And in those of us practicing diabetes, all our decisions are based on numbers. And another big challenge is patients getting these labs done in a nearby small laboratory and reporting the A1C, albumin creatinine ratio, AST, ALT, lipid values not at all matching with the previous values. And based on these results, we need to give a prescription. So all these challenges were discussed, and we were all told that there are some new regulations coming up, including the Data Security Act. And so many things are going to change for good, including the challenges with the different laboratories. There will be some sort of a standardization so that even for the post-COVID era, this will be fruitful and the telemedicine will be existing.
So
actually, one of the biggest challenges that I have is entering all the data that has been sent in, because it's sent as a JPEG format. And there is this major disease in the country called packagitis. that you know, I fail to understand how people get how labs get NABL accredited, because when you're an NABL accredited or a CAP accredited lab, you are not supposed to do a test unless it is ordered by the physician. But a patient goes in for a fasting blood sugar, and they get nickel, molybdenum, chromium levels.
Yes, everything, pages and pages and pages.
Yeah.
So
that's what. And the thing is that 10 minutes of my time is spent on entering those labs into the EMR.
Yes.
So, and then the thing is, we don't know which is right. So I think, you know, I hope you have addressed the packagitis also in
Yeah.
So, like you
TSI.
mentioned about, yes, sorry on Neglusa. Like Dr. Sheshadri and Jyotidev mentioned, there are constraints of the regulation fees also. And there is another 4C constraint is how we would build up the relationship with the patients. When we were used to meet up physically, there was an aspect of relationship building over there, and how the future of those relationship would be built on virtually. Maybe Dr. Sheshadri, Dr. Neglu, any faculty can take it.
So I address this in the thing, and you know, to me, this is a very, very wonderful thing. At least, you know, there have been patients who've been coming to see me for 10 years and 15 years. And I just know them as people who are sitting across my table. I would have a conversation, but it is so different to see them in their homes, with their families, with knowing, you know, some come from such humble backgrounds, and you know, they are so dignified when they come to you, that you know, my respect for patients has actually grown a lot after this. This is one part. Second is, you know, you always interrupted patients in your clinic. I mean, I did. I was always in a rush, I guess. But over a period of time, I've learned that, you know, when I've sacrificed touch, I have to compensate it with my eyes and my ears. And as I type the information, I listen a lot more. And in fact, I had a patient who told me, you know, doctor, in telemedicine, you know, it was so much easy for me to say something to you. You come in person. I feel my daughter told me that she's a little afraid to talk to you. I said, you know, I can be quite intimidating, but I'm actually a nice guy. But what it underscores is, you know, is the art of medicine remains one unchanged. It doesn't change much. And in fact, what it does is you learn to communicate, and you listen, and you respond. You learn and you adapt. I think, you know, that's a beauty of this whole thing. So even now, for the patients who are coming to me clinically, many of them will say, can I show the reports online? And I say, yes. And I think, you know, this is the new normal. It saves time, it saves money, it saves energy. It doesn't replace the physical touch. But I think we as humans are so good that we learn to adapt. Manoj wanted to add.
No, I just wanted to add, when you were speaking about the entire relation building thing, is now that we have these guidelines supporting us and making things clear, one aspect that we as physicians and clinicians need to respect also is the way we'll end up doing any of the teleconsults. And I think that has evolved and needs to further get more rational. And one of the better practices is doing it the same way that you would be doing it in an in-person consult. So to say that if you're fixing up appointments, you're giving a certain amount of time, you're giving your teleconsult appointment as much time and respect as you would for an in-person consult. Very often when this started, people started looking at it means of, doing it haphazardly, doing it at any time of the day, sitting in the vehicle and doing it. And then the whole thing loses the entire significance. So I think that that's important, that give it the same importance and the means, taking down the notes, doing everything. The second aspect, an important aspect, is also the ability to tell a patient no, even if you're halfway through a consult, and telling them that I don't have sufficient information about your problem. I need you to go back, get me some more reports, do certain things. Till that time, I'm not going to. I think sometimes we all being in rush want to just finish it off. We should all have that ability and this thing to take a step back and say no. I need more information to be able to help you do this, or this consult cannot be just done on a video platform or a teleconsult, and you'll need to see a physician close to you or come back to us or whatever. I think that's an important aspect on this telemedicine discussion.
So
Okay,
yes,
before
yes.
you jump, can I add one more point? Just one
Can I-
point.
Can I?
Yeah, Dr. Neglur, one point, and I'll hand over.
Okay, sure.
Just to take from what Manoj says, I think I would think about this as building another kind of practice, which means that telemedicine is not just something for a period of time, but part of your practice. This is one. The second thing is, the only other thing that you need to invest is on a callback. That is, normally your front office takes care of and at least reviews the medication on a physical consult. It's very important to call back and make sure that they have understood. In fact, I've learned a lot of things that I have not been, educating patients correctly in my physical consults, because when we call back, only we realize that what we say and what they understand are two different things. Dr. Neglur, sorry for
No,
interrupting.
it's wonderful listening to you. Talking about the rapport with the patients, I think the patients are much more happier because they say, doctor, you come to our house when you are on a video call. And all of them are sitting and in the hospital with the mask. We can see your face. At least we can talk to you. We know you very well. And therefore, they have a better rapport so far as the video consultation or teleconsultation is concerned. Right, I agree with Manoj and Dr. Krishna Sheshadri in saying that we have to be much more particular in giving instruction to the patient, because we always worried that what we write, patient has comprehended it properly or not. That's very important. Therefore, we need to reassure. So the best way is to get back the reports after 1 week and tell the patient to write back in case if you've not understood anything that what I've said so far, or you have misunderstood what I said so far, that you can tend to recorrect whatever things you said, because many times we use medical language, sometimes in a hurry to answer somebody else's call. At the same time, the phone is ringing. At that point of time, it is better that we tell the patient to get back to you after 1 week. I do not charge them for 1 full month after I charge the first consultation, because they have that freedom to get back to me. And during that time, I can correct all the mistakes either they make or I make. So both can be.
That was a question. Yeah. Yes. Dr. Neglu, that was a question. So we would like to end up this session, but there are two popping up questions to ourselves. One to you specifically. Like you mentioned, is there any need to step up on our insurance to cover the litigation by telemedicine? Or what is, like you mentioned?
I think the insurance company will come forward with this kind of insurance for telemedicine. It is, of course, new thing for them to work on it, because it's brand new. It will stay for quite some time, and telemedicine is going to stay even post-COVID era. So therefore, all the insurance companies are much more wiser than doctors, because they are the first to identify the value of blood pressure. They are the first to identify value of BMI before the doctors could realize the value. So that they are much more smarter people, and they will definitely come up, and we'll have to step it up, because there can be a lot of. Yes, that's
Yeah.
Thank you.
very
Thank you.
Yeah.
So, like you mentioned, same question to Dr. Jitendra, when you build up for the same the question. Like as a healthcare providers, we rely on vitals, history taking, and diagnostic aspects. So, then what technologically support we can have, maybe chat box or whatever would be the future for ourselves to build on the primary care or the primary care aspects of our consultations.
Because the telemedicine is definitely superior, but it is not superior in all specialties. In specialties such as in diabetes, it has proven to be superior. And of course, it is not a replacement for the conventional consultations. The conventional in-person consultations will continue and should continue, but more frequently we can have telemedicine consultations. But one prerequisite will be the patient should have some monitoring equipments at home. Such as during this COVID era, they should have an SpOT, the blood pressure, the thermometer, the glucose meter. So at least 5 devices should be there, including a good BP apparatus. And this will enable for a remote monitoring as a team. So there is sufficient evidence that in some specialties, telemedicine is definitely superior and is going to stay. Thank you.
Like you rightly mentioned, thank you. And to end up the session, the last question to Dr. Chawla, that we know we sit up in the especially metros and tier 1 cities, but how about the urban, the rural part of the India? How would we be able to put on the telemedicines over there or the guidelines, and how we can build further the healthcare?
So I believe the question's to me, Yash, right? So,
Yes, please.
Actually, it's a boon for people in rural areas with the kind of cheap available internet network across the country, and largely reaching out to maximum parts of the country. It's become a boon where a person sitting in a smaller town or a village today is also able to consult without having to physically travel, is able to consult Dr. Krishna Sheshadri in Chennai, or Dr. Jyoti Dev, or Dr. Makkar now, or any of us. I think that means it improves both ways in terms of the physician's ability to have a better reach, to reduce the overall burden on the patient, the need to travel. And as Dr. Jyoti Dev mentioned, in certain fields, it's absolutely fine. Fortunately, in our field, it's a lot to do with numbers. And I think a video consult where you want to see a certain aspect if the patient has a problem is pretty good enough. We very often don't need to, unless a patient has a specific problem where you require a certain physical examination, we very well in our chronic management can do well with it. So even when it comes to simply answer, for rural areas, for a larger reach, telemedicine is a boon. And it may become a norm that you actually in our practice do 3 times a year a telemedicine aspect, and maybe once a year you do a physical checkup.
Yes. Thank you all dignitaries, all faculties, Dr. Neglu, Dr. Sheshadri, Dr. Jyoti Dev, Dr. Chawla, and Dr. Joshi be around. And thank you for making this conference at its best. And we really appreciate for this panel discussion. And let's move to the next session. Thank you. Dr.
Thank you, Yash.
Thank you.
Yash. Yes.
Bye, everyone.
Bye.
And hello, everyone.
Bye.
Thank you so much, everyone, for this session.